thank you very much everyone for joining, and yes, welcome to the South West Learning Disability Collaborative webinar. Just to make sure you're in the right place, this is the Improving Acute Care for People with a Learning Disability Key Learning from NCEPOD's Learning Together report. So I'm Kim Huelin, I'm a Project Support Officer at Health Innovation West of England. I support the collaborative alongside our clinical lead, Dr. Alison Tavaré, who you'll be hearing from later as one of our speakers today, and also our senior project manager, Susie Beresford. So before we start, just a few quick housekeeping points. Today's webinar is being recorded and will be shared on our website and YouTube channel, but we'll also include the link to the recording in our follow-up email, along with the slides and any resources shared throughout the session. Please keep yourselves muted unless you're presenting or invited to speak during discussion at the end. But yes, do feel free to introduce yourself in the chat. It's great to know who's joining us today. And you're also welcome to use the chat throughout the session for questions or reflections. But we have set aside some time at the end for a discussion. And if there's anything that we don't get to, we'll make sure to follow up afterwards. And yeah, lastly, just a reminder to avoid sharing any identifiable patient or personal information in the chat or discussion. So Alison did touch on this, but just for anyone who's new to the collaborative, we are led by Health Innovation West of England in partnership with NHS England South West. And essentially we bring people together to share learning and help shape more inclusive care for people with a learning disability. Our membership is very diverse, consists of people with lived experience, families, carers, clinicians, and it's ever growing. Like Alison said, we're now approaching 600 members, which is very exciting. And although we're based in the Southwest, membership is open to everyone. So please feel free to join. It is free to join. And if you sign up, you'll receive our newsletter and be kept up to date with all our upcoming events, opportunities, and new exciting resources. So on to today's webinar. So a couple of weeks ago, the National Confidential Inquiry into Patient Outcome and Death, or NCEPOD, as we're going to call it throughout this webinar, published its Learning Together report. So the report reviewed the care of adults with a learning disability who were admitted to hospital and acutely unwell. It's been particularly encouraging for us as the collaborative to see this report published, not only because it shines a light on a very important area of care that hasn't received enough attention nationally, but it has a connection to the Southwest. So the idea for the proposal actually emerged from discussions between the collaborative and NHS England Southwest, which then brought together colleagues from Royal College of Nursing, the Royal College of Physicians, Royal College of GPs, and LEADER, who then helped to shape and develop the proposal. But it was Jonathan Beebe, the professional lead for neuroscience and learning disability nursing from the Royal College of Nursing, who went on to lead the proposal that ultimately became the Learning Together report. And he was due to join us as a speaker today, but unfortunately is unable to. But we still really want to acknowledge and thank him for the role that he played in leading this work and, yeah, bringing it to life. So this is our agenda for the day, giving you an overview of what's ahead. And we're delighted to be joined by colleagues who are closely involved in the review and who will be sharing their insights today. We're going to be exploring key findings and recommendations alongside examples from the Learning Disability and Autism Liaison team at University Hospitals Plymouth, whose work brings to life many of the examples of good practice highlighted in the report. So without further ado, I'll quit yapping and I'll hand over to our first speaker, Dr. Rachel Gaywood, who will begin by providing some background and context to the review. So thank you.
Thanks, Kim. Hi, everyone. I'm Rachel. I'm a GP down in South Devon, and I work for NHS Devon as the clinical lead for learning disability and neurodiversity. And I was also one of the reviewers for NCEPOD, which was a really great experience. If anybody gets the opportunity to do it, I would really recommend it. Lots of really valuable learning for the reviewers as well as wider. So if we can go to the next slide, we're just going to talk a little bit about why we needed this study. And then I'm going to talk a little bit about the definition of learning disability and identification. So we know, don't we? We know in the long-term plan that gold standard care for the most vulnerable adults in our society is key. I don't know about you, but I think we talk about things a lot. We talk about health inequalities. Everybody says how important it is, but then what we really need is things like this report, is actual action that gives us clear guidance on how we could do better, rather than just sort of tick boxing to say we've mentioned it. So this is a real valuable piece of work that we can use to improve delivery in the future. We know about LEADER. We know that people with a learning disability died 20 years younger than the general population, and that half of those deaths were avoidable. This is the bread and butter stuff that we talk about in learning disability every day, isn't it? But still shocking when you read it and you put it down in black and white. So that's double the incidence of avoidable deaths in the general population. So identifying in acute care settings how we could better support people with a learning disability hopefully will go some way to improve those numbers. We know that LEADER repeatedly identifies that people don't just have the one reason why they go into hospital, but multiple health needs and many barriers in accessing the healthcare that they need, whether that's communication, whether that's Mental Capacity Act, whether that's not being offered reasonable adjustments, many reasons for that, which we see time and time again. We can go to the next slide. So we know that there are within trusts are improvement standards that people can sign up to, but I don't think that they're mandatory, and they don't seem to be fed back, as far as I can see, anywhere sort of higher than the trust themselves. So it's great if you've got somebody, an enthusiastic team who are really driving that. But we wanted to try and get a wider view across all trusts of what was going on, and that's never been done before. There weren't any large-scale UK studies that focused on the variation in delivery in the acute sector of people specifically with a learning disability, regardless of whether they left hospital or not, whether they survived or they didn't. Obviously we have LEADER, but we know the outcome in LEADER. This is to really see if there's anything that we can do to improve care for people should they be admitted again. So there's work going on out there, but this really adds by looking at how the emergency care is provided to all people with a learning disability and not just those who died. So really important work. We go to the next slide. Now, one of the big topics which is being discussed kind of nationally at the moment is the identification of learning disability. So we thought it was really useful just to reiterate the definition. So to be defined as having a learning disability, you need to have three things. So you need to have the impairment in intellectual functioning, so that cognitive impairment. Now, we don't really use IQ anymore. Very few people actually get an IQ test. So we need to be thinking about other ways of identifying that. The significant impairment in social functioning, so able to live day to day and carry out those activities of daily living, and it needs to have started before 18. Just bear with me if you hear my dog shouting. She gets very jealous when I'm talking to people on Teams, so I'll move if I need to in a moment. So yeah, this is what the Department of Health defines the learning disabilities as, but we will all know that that's not so straightforward in real life, day-to-day practice. So if we go to the next slide, what we're really discussing a lot at the moment is how we identify people, because we know that nationally we don't have diagnostic pathways to diagnose learning disability in adults. Some of our specialist teams will confirm or look into a formal diagnosis if that's helpful in their general care and sort of formulation. But certainly within general practice and within acute trusts, we don't have a way to diagnose, so we really need to just be identifying people. We need to be noticing if somebody has what we think is a learning disability and asking them about reasonable adjustments and asking them whether they are on the learning disability register. So for those of you in secondary care who don't know specifically about the learning disability register, this is the list that we hold in general practice that tells us who to invite for an annual health check. So you don't have to have a diagnosis of learning disability, but what happens is that certain codes on the GP records will be pulled out, and those are the people who are on your learning disability register. So that's really important to understand, because somebody might have a code that doesn't get included in the register, such as learning difficulty, and so we know that people are confused about the difference between a learning difficulty and a learning disability. So something like dyslexia, dyspraxia, anything that may cause you a difficulty in learning but doesn't affect your cognitive processing. So really important that we are all aware of that as the people who are working in learning disability, so we can disseminate that information out. As I said, there are national discussions about identification and diagnosis of learning disability and the challenges that poses. For me, I always worry about the people who are not not receiving 24-hour care, not the people who have a severe or profound, if we were defining it like that, learning disability, but the people who would have been classified as mild learning disability. So those people who might be living independently in our communities with a bit of support, but who we might never see, and we might not know about them, for example, until they became acutely unwell, or until one of their parent carers is no longer able to support them, and then we meet them as they're already an adult and they've got lots of health needs that we were never able to pick up before. So that's why it's really important that we can identify learning disability. If you go to the next slide, the tool that we recommend GPs use, but I think is valid across settings, is this inclusion tool that was made by the team in Leeds. So those of you who don't know, the Leeds Get Checked Out team have loads and loads of really great resources, and this is the resource that NHS England sort of endorsed for use in general practice to identify if somebody has a learning disability. So you can see there it reiterates the definition for us, and then if we go to the next slide, it's essentially a checklist which helps the GP to decide if somebody should or shouldn't be in the on the register. But there's no reason why other professionals can't use that and use that in conversation to support people, to say, please can you make sure I'm on the learning disability register, so that I am flagged whenever I come across healthcare professionals. So if we go to the next slide, as I won't go through all of this, it's available, it's readily available, but this just helps us to think about what might indicate a learning disability if somebody isn't actually diagnosed as such. So the next slide, please. There you go. Hopefully I didn't go too much over time. I'll hand over to Alison to take us through the summary of the report. Thanks.
Oh, you're on mute,
Thanks.
Alison.
Yeah, thank you. Sorry. Thanks, Rachel. And thanks for just giving the definitions as well, and also explaining some of the inequalities, which were the reasons that we made this proposal as a group to NCEPOD. And thank you also, Kim, for mentioning Jonathan Beebe. We want to really highlight his role in doing this. It was submitted by the Royal College of Nurses, which we're really pleased about. So, as Kim said, I'm a co-lead of the South West Learning Disability Collaborative, but I'm a GP by profession, and I'm also a clinical coordinator at NCEPOD. So I was one of the coordinators on this report, and my co-author is David McWilliams, who's a professor of critical care and a physio by background. So what I'm hoping to do today is just give you a quick overview of some of the findings and some of the recommendations, share some of the resources, and thanks to Saoirse, who's going to really highlight some of the work that can be done in hospitals and the benefits of having a learning disability team embedded in providing care. And then I'm just going to ask a few questions. There's things for you to think about your practice and whether there might be areas that you would want to improve. Next slide, please. So very quick thing on NCEPOD. It's a national confidential inquiry into patient outcomes and death. And what's different is that it's the suggestions for improvement are made by clinicians. And we want the aim is to improve the care given to patients. So some other reports published recently were looking at limb ischemia and then emergency surgery in children. One that's going to come out soon is pleural procedures, such as how you put chest drains in. So very much clinical led. And it's not an audit or research, but it's a snapshot. And what's so different is we have the ability to look at the notes, and people like Rachel provide immense skills of reviewing. And I'm not sure if Emily Richardson and other colleagues who were reviewers of the notes are on this call, but reviewers are so key to what we do. And if anybody wants to get involved, please do. It's really it's great to have MDT working. And so we also triangulate this information from the notes, from the reviewers, from the clinicians who've provided the care, from the hospitals who say what they're doing. And then we also have focus groups, patient surveys, and online professional surveys. So a lot of data. Next slide, please. And I should mention, actually, when you see the QR codes, if you take pictures of them, we will share the slides, but that will take you directly to some of the reports that I've been linking. So as Kim said earlier, the objectives were to identify avoidable and modifiable factors associated with poor quality of care. And we were looking at all patients with a learning disability aged 18 or over who were admitted as an emergency over a 6-month period. We identified nearly 13,000 patients. From that, we looked at 1,000 patients for further review, and from this, we got information from the 666 clinicians who reviewed the patients. We looked at the case notes. That was a significant piece of work because every single case note was there, had to be anonymised. You can imagine how much information was there. We also have information from primary care questionnaires. 199 hospitals completed organisational questionnaires, so significant involvement across England. Over 800 health and social care professionals, and then also patient surveys and carer surveys. Next slide, please. And so we made 5 recommendations, and the first was to accurately record a person's learning disability in the patient notes and on learning disability registers. I won't talk about the definition because thanks to Rachel for doing that. But what we really found really surprising was that a third of patients had learning difficulty rather than learning disability in their notes. And the two terms are often used interchangeably. And so we wonder as how many patients who were only coded as having a learning difficulty rather than a learning disability weren't identified. It's a recurrent theme, and I found examples not just in clinical cases but also are nice. The latest sepsis guidance spoke about people with a learning difficulty, and thanks to Ken Courtney, the National Clinical Director for Learning Disabilities, who got that changed. And then we also found terms such as shortened to learning disability. And in one clinical entry, the clinician writing the notes had written LD, learning disability and learning difficulty. So you can see what a challenge there is. So, you know, that's something really to think about. Next slide, please. And so if we know somebody's got a learning disability, how do we share that knowledge? Because it's not just for the person in front of you now, but it's when they come back next week or when somebody else sees them in an outpatient's appointment. And so nearly 90% of organisations said they used alerts or flags, but actually only just over 50% of patients had alerts. So hospitals say they're doing one thing, we're not quite finding that. So the questions I'd be asking is, do the admission team know someone has a learning disability when they arrive at the front desk? I'm going to share a video later, and that very much talks about the issues when somebody with a learning disability arrives and their behaviour is more challenging and people don't know why. Do you have alerts and pop-ups? If you know someone's got a learning disability, how do you let the learning disability team aware of what's happening? Saoirse will talk about that. Do you have it if you've got electronic patient records? Is that on the hospital passport? Alex Barkley from Heart says she does a virtual round every morning of everybody with a learning disability in hospital. And then the other bit that I wanted to also mention is the miscoding, which we've just touched on. Next slide, please. And so this obviously is the tool that Rachel mentioned, that if you have a look at the QR code, that will take you straight into the tool. Next slide, please. And I just wanted to share some, one of the things we do with NCEPOD is look at practical solutions. And Alex Barkley is a critical care outreach nurse working in Hertfordshire. And this is what they give to their patients with a learning disability. So you have a wristband saying that, giving your hospital details, a wristband with your allergies, and then have this one to show that you've got a learning disability. Apparently, they've only had one patient ever say no. Most patients find it really helpful. The carers and the families really like it. And it means that not only do the clinicians delivering the care know someone's got a learning disability, but also the porters, the housekeeping staff. You might need a bit more help with your food. You might not be able to complete the order for lunch. Really simple strategy, low cost, which can raise awareness of what's happening. So have a think about that. Also looking, it's got Martha's Rule telephone number on there, which we like. Next slide, please. So if we know someone's got a learning disability, how can we remove those barriers to care which are required under the Equality Act of 2010, so known as reasonable adjustments? We found that reasonable adjustments were much more likely to be made if there was an alert in the patient record. But patients and carers often weren't asked about the reasonable adjustments, and there's often that lack of understanding that reasonable adjustments can be organisational, so it could be disabled parking, accessible loos, but they can also be very individual. So for one person it may be that they get really distressed by noise, so they need headphones. How do you know what can help that individual? And if you can help that individual stay calmer or be involved, then that will provide better care for them. But also I feel makes it easier for us to deliver the best care for as well for that individual. And reviewers found that if the carer was involved, reasonable adjustments were much more likely to be made. And one reviewer said the carer knew the situation well, reasonable adjustments were made without a second thought, and they worked closely with the family. Next slide, please. So if we know what reasonable adjustments help, are they being flagged in the notes? And as you can see, in the acute hospital setting, only about 50% of clinicians said yes. And this is good information. Why aren't we sharing it more in the community, but still room for improvement? And that's probably this lack of flagging of reasonable adjustments probably reflected in the fact we found that there was documented evidence of reasonable adjustments being made for only just over 40%, and for 21% of patients they were made inconsistently. So having the alert made it much more likely adjustments would be made. But interestingly, less than half of the health and care social professionals thought it easy to flag adjustments. And where's the low, is that a low cost intervention that you can make to start raising awareness? Next slide, please. Because adjustments don't have to cost money. This was one that carer said that rather than the person she looked after waiting in the surgical ward, the day surgery unit for an operation, that the person was able to wait in their own room, and therefore they were much calmer, and therefore that made life easier for the patient, the carers, but also the staff delivering the care. So it's often not complex. Next slide, please. If you want to know more about reasonable adjustments, the Royal College of Physicians have got a great tool. Again, it's the Acute Care Toolkit based on some work from Hertfordshire, and the video I'm going to share later also talks about these aspects where you can look. So the thing I would say to you is what reasonable adjustments are available in your organisation? What's available in your department? Do you have noise cancelling headsets? How do you know what reasonable adjustments could help? Do you have flags? Is it written on paper, which therefore it's less likely to be accessible? Do you ask carers who might be able to share practical solutions? And how do you share what reasonable adjustments help? Next slide, please. And so, as I've just mentioned a couple of times, this is Gavin, who is an expert with lived experience for learning disability based in Herts. He's recorded a really fantastic video last week for the NCEPOD launch. Hopefully it'll be on the website now. It's about 13 minutes long, so not too long. A lot on adjustments, but also quite helpful flags on making mental capacity assessments. So if you've got time to have a look at it later, do so. Next slide, please. The third recommendation is to use decision support tools to assess mental capacity assessments. And the bit that we really have to emphasise is that a person with a learning disability shouldn't be presumed to lack mental capacity to make health-related decisions. The reviewers tend to review the notes often in the same room, and it was a recurrent theme that, you know, a statement had been made, person has a learning disability, so unable to make that decision. It might be that they can't make a decision, but actually most decisions vary. It might be with, do you want a cup of tea, or it might be you need some surgery. And if people are making more complicated decisions, what information can we provide so they're able to do so? And this lack of understanding amongst clinicians on capacity is reflected in the fact that formal mental capacity assessments were made consistently for about 30%, inconsistently for about just under 10%, and not at all for about 60% of patients. So we know, Leader knows that delay and problems assessing capacity can have negative impact on care. So how can we improve this? Next slide, please. The decision supports can be of use, and they are present in 95% of hospitals. But what really surprised us was that despite the decision support tools, just over half the patients who didn't have a formal assessment were considered by the reviewers to have needed one. And what was even more surprising was that nearly just over 60% of healthcare professionals who have assessing mental capacity as part of their role didn't feel confident to do so. So what is happening that people don't feel confident to assess capacity? Next slide, please. And the impact, it can be considerable. So I thought we found a lot of issues on accessing CT scans. And I've had quite a lot of involvement with our local hospital, and they were saying often just they want simple things like having a double appointment so that you've got longer to explain to somebody what a CT is. And this was a man in his 50s who had pneumonia, had a hemoptysis, likely to have a pulmonary embolus, but he refused the CT scan. So they said he couldn't decide. They therefore commenced anticoagulation, so making his blood thinner for a PE without confirmation. So given quite significant medication with no diagnostic proof. And I can imagine when that medication was reviewed at a future date, somebody could easily say, well, there was never any confirmation, so does he need to continue? And so by not involving that man and giving him the access to investigations, negative impact on his care are particularly important, because previously giving him time for the CT had meant that he'd actually agreed to CTs. Next slide, please. And if you want to know more about mental capacity, this is a video the Learning Disability Collaborative produced with some practical tips. It was to support annual health checks, but all the learning is relevant. And the questions I would say is, do you feel confident assessing mental capacity? How do you record your decisions? Are decisions part of a patient's electronic patient records so they can be reviewed? And do you have access to a decision support tool? And I would also say, do you have a mental capacity lead in your organisation? And if so, can you ask them, how can these problems be addressed? Next slide, please. If you want to know more, this is some advice. This is some guidance produced by NHS England. It is actually for acute settings, but we've just updated it for out of hospital settings. It's going through its final approval with NHS England. As you can imagine, with all the challenges going on, it's taken a bit longer, but the principles are the same, and it's a really useful resource. Next slide, please. And the fourth recommendation is to involve people with a learning disability in their care, and also the carers. And found that only just over half patients were involved in decisions regarding their care. And significantly, in just over 40% of cases, there was no involvement of the patient or the patient's carer at discharge, which we think has an impact. Carers were involved in about 45%, but it was inconsistent in about a third of the cases. There was often no involvement of the patient or carer in planning ongoing care. And we think this is particularly significant because a fifth of the patients were readmitted within 30 days of discharge, more than 3 times higher than the readmission rates for people without a learning disability. So what's going on? Why are people bouncing back, particularly when nearly 60% of those patients who were readmitted, it was related to the original admission? So what's going on? Why are people coming back? Is this because they're not involved in their care? Next slide, please. And so if you want to involve people, what information can they bring in? Thinking of hospital or health and care passports, Saoirse is going to go into that in more detail, but it's a great opportunity to find out what's going on, what's normal for that person and where the changes are. Passports certainly make a difference. Next slide, please. We can also ensure that we take observations as recommended by the Patient Safety Alert of 2018, should take a full set of observations. So, but it was found that 15% of patients didn't have a full set of observations, so they lost the value of News 2, National Early Warning Score, to identify when they were very sick. Most commonly missed elements were consciousness level and respiratory rate. And if you think of respiratory rate, we don't need to touch anybody. You can stand at the end of the bed. So why is that not being recorded? Particularly as a clinician, that's the most sensitive. If I could only have one observation, that would be the one. If subtle increases in respiratory rate, can support deterioration. And pain wasn't recorded for about 85% of patients. So if somebody's behaving oddly, could they be in pain? Why is that not being asked? And you can see the potential of News 2 if somebody's unable to give a history. In this case, 30-year-old man, and News 2 was 9, therefore immediately escalated as being really sick, had sepsis, and the right care was delivered at the right speed. Next slide, please. And not just taking observations, but also talking about the soft signs, which are really key. All carers I know say they can set, particularly family carers, because they say they know when the person they look after is unwell. And for those of you who know, I've got a nephew with profound learning disability. He can't speak, but he's very noisy. We know he's in the room. When Toby's quiet, we know he's sick. That's a really important soft sign that we as clinicians, as healthcare professionals, need to listen to. And this case was lovely because the carers just said that the person they looked after says woo-wee when she's happy, and when she's not, she frowns. And it's that kind of subtlety that you can see there's a change in someone who can't tell you they feel more unwell. So I just ask you, do you ask families and carers about soft signs? And if Emily Richardson's on this call, I know it's something that she's thinking of looking at in the Bristol area. So do kind of watch out for that work if she manages to land it. Next slide, please. And so what do carers want? They're so important. The most common support offered by hospitals is open visiting hours, although in fact often people said that didn't happen. But this carer survey said what they really wanted was free parking, practical. They also wanted access to loos. If you haven't got access to, some of the carers I was talking to with Susie, our senior project manager, was saying, if you don't have access to a loo, if you can't use the staff loo, you worry about when to go, and you can guarantee that the ward round happens when you're out of the room or some crisis happens. Could they have access to a staff loo? Doesn't cost money, but what about that? Parking top of the list, but not prioritised by hospitals. And another thing carers asked for was refreshments and meals. Again, it means you haven't got to leave, but it also acknowledges some of the significant costs of trying to buy food on site, particularly if you're driving distances, worrying about where to park if you're looking after somebody. And the question I'd ask you is, do you have a carers policy? And if so, what's provided? Next slide, please. And do look at, this is some work from Norfolk. It's got some really great ideas on their website, but some of it is just having a lanyard. I'm a carer, so people know if you're using the staff loos. If you're going down to perhaps get a cup of coffee, perhaps you could, if you want, it's important not to have to be kept waiting in the line. But most of the carers thought a carer passport would be really helpful. Lots of different ideas in different hospitals, very happy to talk about that, such as a carers hub, which can help support carers. Next slide, please. And also I just wanted to highlight this one, the Learning Together patient leaflet, which the NCEPOD team produced. One of the main things was to tell staff you have a learning disability. I think sometimes people are like, oh, I don't know if I want to say that, but actually people with a learning disability often say they want others to know. So be upfront, say that's what you've got and you need some help. Ask for adjustments, bring your passport, and then ask about the learning disability team. And before you go home, just check what's being decided. In the discharge summary, only 40% were coded as somebody having a learning disability, a lost opportunity to populate hospital records. But that's, can you update your your discharge summaries just to include that coding? Next slide, please. And the final one is to commission local learning disability support services to improve the care. So Saoirse is going to give much more information and practical examples, but we found that only 20% of hospitals were these learning disability teams multidisciplinary. Most were single profession, and actually the majority, 40%, were a single individual. I gave a talk last week in Northern Ireland, and it's one nurse dealing with all the trusts. I mean, I'm doing amazing work, but one person obviously can do much less than a team. And learning disability teams are often only available during weekday hours and sometimes only limited support for emergency admissions. It's particularly important because learning disability team involvement was associated with better care. But I would also suggest that it's not just learning disability teams have the opportunity to develop to be involved in day-to-day care, but they can also be involved in upskilling all of us, all the healthcare professionals delivering the care, so that we feel more confident to assess capacity, make reasonable adjustments. And an example was given to me last week of a dentistry team who look after people with a learning disability. And working with the learning disability team, they've developed an accessible pathway. They've got the reasonable adjustments. They're confident in assessing mental capacity. And they've actually now delivered this with actually no involvement of a learning disability team, which to me is actually what we should be doing, is that the learning disability team, yes, they can be helpful day to day, but they can also help upskill and provide the teams the confidence to deliver the right care at the right time, and particularly in the middle of the night when there's less, when other colleagues aren't going to be available. So next slide, please. So I hope that's been a really quick overview, but I hope that's been helpful. And the lessons I would suggest to take away are, first, to identify code and share that someone has a learning disability. David and myself were talking last week about what we feel is the most important recommendation, and we feel this is key. If you don't know that somebody's got a learning disability, then actually most of the other stuff can't happen. Raise awareness of the importance and impact of regional adjustments. We know they can't always be made all the time. In a busy ED with a long waiting time, it may not be possible to offer a quiet room for someone to wait, but it might be that somebody has a favourite toy, and if you can ensure that that favourite toy is there for them to cuddle, then that could make them feel much more confident, much happier, and much better able to work with others to find out what's going on. So they don't have to be expensive, but we recognise that regional adjustments can't always be delivered. We need to upskill and improve clinicians' confidence to assess mental capacity. That's a really key one. Have we got, there are tools, but how many electronic, can they be embedded in the patient's electronic record so you can support, so it can help you make decisions, but you've also got a record there for somebody else to refer back to easily, and also can help audit trails. People with a learning disability and their carers should be at the centre of decision making about hospital care. Unfortunately, we found that DNA CPRs were written without access to discussion with patients and their families, and that acute hospital learning disability teams should be involved. But the main one, and this comes from Anthony Mikulski, who's another clinical coordinator at NCEPOD, and as he said, we should understand that meeting the care needs of people with a learning disability is everyone's responsibility, not just that of specialist services. We've all got a role to play to improve the care we provide, and let's hope we can improve the health of people with a learning disability. So thank you very much for listening. And I'm now going to hand over to Saoirse, who's actually going to show how a lot of these recommendations and learnings are actually happening in Plymouth. It's great to hear what she's doing. And thank you also for lots of resources, which we'll share later. So Saoirse, over to you. Thank you.
Good afternoon, everybody. My name's Saoirse Reid, and I'm the nurse consultant, learning disabilities and autism for University Hospitals Plymouth. We have a main site, Devon Hospital, and other sites, but we mainly work on one site, which I know is very different to other liaison services, but at the moment we focus on the main hospital. We're also an 8 to 4 service, and we are a 7-day service, At the moment we're doing 6, but we had some recruitment issues last year, now fully recruited into, so we will be running a 7-day service very, very soon. An interesting discussion there around what happens after 8 till 4. And we had discussed at one point looking at an on-call service for the region, so whether or not that's something we might want to approach, which would mean that one of the liaison nurses across the Cornwall and Devon would probably have to do an on-call week, maybe once every 10 weeks. So again, it's about how do we get that up and running and agreed, etc. So this is currently our team position. It's took 12 years to get here. Originally, the service started, as with most of the trusts, with one acute liaison nurse, who was a band 7 at the time, full time, and then was joined by a second from Cornwall, because we provide services to Devon and Cornwall, with it being a major hospital. And that's initially was those 2 nurses trying to do everything. So over the years, I joined the team as one nurse retired and went down to a 2-day week. And then we started building from there, because it is quite a large population it serves. So I sit directly under the Deputy Chief Nurse, which is brilliant. It's great to be in that position, because anything that's even day to day, we can escalate quite quickly. We can also be advocated for our population groups, but also the teams work at quite directorate level. So we've got really good support as well from our chief nurse and our board. And so I know different liaison teams work differently, but I think that's, in my opinion, the best place to sit in terms of getting the support and leadership that the liaison team needs when walking across sometimes lots of different services and patches. We also have a medical lead for learning disability, so we've had a medical lead for about 5 years. Again, it took a considerable amount of discussion to get that medical lead. They do a 2.5-day week, so not loads, and mainly help us with subject judgment reviews, but will also every now and again consult very complex cases, especially around palliative care, because the other hat is, well, the main hat is palliative care lead in the trust. We also have a manager, service manager, band 8A, a clinical lead, so that's the day-to-day management of the team and coordination of the work. We have 3 band 6s. We now have a band 5 that we've grown ourselves through the Marjan Aspire programme. So that's my second hat. So I'm actually the lead programme, co-lead programme for the Aspire Learning Disability Nursing Training Programme at Marjan University. So we've been able to grow our own, and that's been really useful in progression planning. I got into that because I was really passionate about making sure there was more learning disability nurses on patch, especially local, and really make sure that we have enough people in the workforce for when some of us will retire in a few years. So we also have team assistants, and a lot of places don't have these, and they're absolutely vital, because there's lots of our liaison work and role that is administrative, and that actually a band 2 or 3, depending on your organisation, what they are, can take a lot of that off, which means the nurses can go out and work more clinically. Next slide, please. So my background, so I know a lot of acute care services don't have consultant nurses. I think in terms of Devon and Cornwall, I'm the only one across patch. And I think it really does help give assurance up to board around the compliance that it needs in terms of making reasonable adjustments, and any other papers like this one comes out, the recommendations, benchmarking it, are we doing it, can we do things differently, and then making those changes or supporting others to make those changes. Again, so I'm consulting, I was line managing last year and consulting and doing some clinical work. However, because we've made those changes and having the band 8A, I can step away from line manager and really focus on not only supporting the liaison team, but I support other medical teams, surgical teams in terms of how they might improve their own services, or I might go in and consult expertly on very specific or challenging cases, especially those that might end up in court. So they've got that extra expert advice. And I own and review the learning disability and autism policy, and I'm happy to share that. And again, it's all ages, so just so you're aware, we stopped doing the adult and paediatric separately, and we're an all age service. So again, we look after support people with learning disabilities, and we support autistic adults without learning disabilities. Next slide, please. So the actual nursing process, so as mentioned earlier, alerts are very, very key. So we have 4 main alerts that we use. We have one for learning disability, LD is an attribute, that's what they will see on the screen, but when they hover over it, it will say learning disability. This person has a learning disability, or is alerted, not learning disability diagnosis, alerted as having a learning disability, please do this. We also have an alert for HP hospital passport. So again, staff member can go over that with a mouse and it'll say, does the person have a hospital passport, or we'll mark it if they do, and it'll say, please read the hospital passport. So that's important. I'm going to talk about that a bit later, so I won't go into it too much now. We also have an AS attribute for if the person's autistic, and that's 3. So we have somebody who self-reports, so doesn't want a diagnosis, but they're self-reporting as autistic, they will get alerted. We also have people waiting for assessment, so we'll alert them as that, and then we'll have people that have had assessments, and we will see all of those individuals, so we don't exclude on the basis of having a diagnosis or not. All new learning disability patients will be seen within 24 hours, so we'll come in, the team will come in that morning, and they will have a virtual patient list for learning disability and one for people who are autistic, and then they will review, they'll know the people that are new, and they will make plans who they will visit that day. So we are going to Epic, it's all very new, and we've took the opportunity where we were very paper based, so we would be having put stickers and notes, which is our care plan around, you know, checking if the person needs reasonable adjustments, have they got a passport, would we advise adults, things like that. So we would have that as part of our nursing process. So we've now put that into a care plan I'm happy to share, and part of that care plan will identify things like the social backgrounds. Have they got pets at home? Are they caring for somebody at home that we might need to know about? Are they under safeguarding? And then part of our key job, after gathering maybe some of that information that in an emergency admission is not always gathered, we will then look at the reasonable adjustments, and we actually have a reasonable adjustment risk assessment tool that's digital, we can share, that we use, that will help identify the level of the person's need, which is low, medium or high, but also specific individual reasonable adjustments for that person. The staff will see that they have that reasonable adjustment form completed, because they will be alerted as RA, so that was the final alert, and they'll be able to hover over that, or say, see the reasonable adjustment risk assessment tool and recommendations, and they'll be able to go in and see reasonable adjustments needed around communication, extra support that they might need, if they've got any sensory issues, if they need a side room. So all of those reasonable adjustments will be on that form. And the key thing is just making sure that staff are alerted to it and read it once we complete it. So in terms of our autistic populations, what we tend to do is, because they're usually a lot more able to advocate for themselves, so we have introduced a pack for them, and it has different types of hospital passports that they might want to use. It also has a self-assessment for themselves to say, well, okay, I'm on this ward in this environment, what do I need? And they can sit with a nurse, not necessarily us or somebody or the partner who's with them, and they will complete that and then inform the nurse of it. The only time we really get involved after that point is if the case becomes specifically complex and the person becomes non-compliant, then we might get involved a bit more and do some direct support with that individual, because the key thing is that they are compliant so they can get well and go home. The same with paediatrics, we often find that they're well advocated for on the paediatric ward. So again, we just make sure that they have the resources. We have paediatric link practitioners who are great, and they'll make sure that they're all up to date. And we only get involved if there's, you know, a complex need or a family or requesting support to maybe speak to a consultant. that type of thing. And then we evaluate the care and the feedback. So we send out our own, they have family and friends, but we also send out a plain English version to those who are autistic who's just been in hospital, and we also send out an easy read version, and then we review them annually and come up with some ideas about how we can improve our services. Next slide, please. Thinking about time. So the outpatients, so we have a dedicated role at the moment to look at outpatients. So they will look at advanced bookings, ring them up, see if they need support. They'll also follow up on our 2-week waits. So we get notified about our 2-week waits now. So they're not waiting longer than 2 weeks, especially if they need a GA or some sort of sedation to have an MRI scan. So we pick them up early, and they'll also follow up on DNAs. When we've had it as a whole team doing it, this work seems to get lost, especially in winter, in the busy months. So this is why we have a dedicated role for it. Next slide, please. So what else? Well, there's lots of other things the team do. So we lead on our engagement group, so it's Derriford User Group and Derriford Autism Group. And again, there is a real concentration on improving services. So they've campaigned for communication boxes, books, changing places, facilities, and this is after doing mystery shops. So they've actually done like quite a lot of work. So if anybody wants any support or information about setting up an engagement group, do let me know. We lead on our monthly GA clinic, so this is so people can be planned to come in and have procedures that they don't particularly like under sedation or GA. We do training for the trust. We also support our leader reviewers. We complete our subject judgment reviews. We do our link to link with our practitioners or our champions, maybe you call them in other areas, and we have 162 in the trust. So if anybody wants to know how to get that off the ground and support with that, let me know, because we use a reasonable adjustment heat map that they do every year, and we produce that to board, and wards or departments can be gold, or they can be red, which is not very good. It's usually picked up. Why is that ward red? And it just means that they've been doing 2 or 4 or more reasonable adjustments a year in their department to keep on top of things. So it's not a certificate, it's an ongoing thing that we do. So we provide teaching to local universities, and we also actually support our colleagues who are neurodivergent. Sometimes I might get a call from a manager to say our administration team, some people are neurodiverse, can you support us with that and the environment that they work with? Next slide, please. So that's some of the thanks to the team. So we do get a lot of thanks, and I make a point of making sure this is in our annual report to the board to show the appreciation and the impact that the team has, and I think that's really important. We also use patient stories when we report into our quarterly, we report on safeguarding. It's really important for liaison teams to show their impact, and if that's true, thank you to patient stories, that is the best way to go. Next slide, please. So because we've got a larger team, and because I can drive quality improvement now in my position, when I was managing the team and a consultant nurse, I could only get half of this done, but I'm in a much better position now to drive quality improvement, not only from our team, but across services, which is brilliant. So the Wait Well project, so reducing waiting times for people on certain specialty lists were waiting longer. So we've now put together a triage bookings form for the bookings team to escalate people that might fall into that long wait. We're also doing a priority pathway for 2-week waits, because it's very difficult to arrange off-the-cuff GA with the people that you need in that room to support that individual within 2 weeks. So we're looking for a pathway, so our team aren't having to do it all the time, and that other teams own that pathway, like oncology. We're going to talk about the hospital passport in a minute, and we're going to do the Oliver McGowan in-house training team, but I'll leave the rest for you to have a look at. But I think that's key. It's not just about seeing patients, it's about how can we make things better across the trust in certain areas, etc. Next slide. So we now have a hospital passport app. It is based on the Gloucester original readapted hospital passport passport, the paper version, so the traffic light version. Next slide, please. What we found is that lots of people were losing them, not bringing them in, and the information wasn't ready. So we did this with the user group, and we co-produced the actual app. So it has been done with the service users. What they wanted is for it to look the same. They didn't want to have to relearn or get familiar again with another hospital passport they've been using for 10 years. And the staff, when we got staff feedback, basically said the same. Next slide, please. So it went live in 2022, and you can get it from your Play stores. Next slide, please. And yeah, you can skip the next two slides. It's just what it looks like. You can have a look at that. The pain one is in there, so them soft signs. We did have to go through governance for this, but it's a patient-owned document, so it is not a medical record, and that is how we got it over the line. That's the key thing. Next slide, please. So yeah, where we are now. So there is a link on this slide where you can go on and get all the resources for the hospital passport app, easy read, how to sign up. It's free for everybody. So in your area, people can use it. You just won't have access to the staff hub. But I'd still encourage people to use it because they can now print from it. So they can set up a PDF file or get support from somebody to do that and email it. So if they are in hospital and have got the app, they can just arrange and email it to the admin if they're in ED or on a ward. So just so you're aware, people can use it now. And I know I'm out of time, so I'm not going to go through any more. I'll be in trouble. Thank you very much.
Thanks so much, Saoirse, and that was really helpful. And one of the things I really like is the way you look at a complete pathway. And as I mentioned for the dental pathway, I couldn't help but think about investigations because colleagues from UHBW, I don't know if Elise Sandiford's on the call, but identified that people with the advice and guidance doesn't ask if somebody has a learning disability. So how can we make reasonable adjustments? So I'm going to hand over in a minute to Kim to close. But before we do that, we've got in 2 minutes. We apologise for not having chance for questions. If you put them in the chat, we'll see if we can answer them. How are you going to change your practice? So what I'm going to ask you to do is just after today, is there one thing you could put in the chat before you press return? So just think one thing you might change. Are you going to look at reasonable adjustments? Are you going to look at referral pathways? And then what I'll just do is 3, 2, 1, enter, and we all enter. Everyone enters at the same time. We can see what the themes are, and that might be helpful to take back. I did it last week at Queen's University in Belfast. A lot was on reasonable adjustments. So perhaps if you'd like to write something in your chat. Yeah, and as Kim says, if you've got any questions, we'll try and follow up, but hopefully we've given lots of information. So I'm just going to say 3, 2, 1 now and enter. So let's just see what themes people have got for ideas. Referral pathways, accessible information, flagging, hospital passport. Yeah, and we can certainly change some sources. Identified coding, reasonable adjustments, MDTs. Thank you. Well, that's brilliant. Thank you so much to Rachel and Saoirse. It's been fantastic. I'm now going to hand back to Kim, who's going to close the session.
Just echoing what Alison said, thank you so much to Rachel and Saoirse and yourself, Alison, for all that, sharing the work and insight. It's been great. And sorry we didn't have much time for questions, but we can get back. If you have any questions, we can answer them in a follow-up email. We'd also really appreciate it if you complete our short feedback survey, just to let us know your thoughts on today's webinar. And yeah, looking ahead, our next couple of webinars over the summer are going to focus on Martha's Rule and improving approaches to psychotropic medication for people with a learning disability. So if you're a member of the collaborative, you'll hear more about how to sign up over the next month. But yes, thank you so much for joining today and hopefully see you soon. Thank you, everyone.